Thanks for joining us here, everyone. Today I'll be talking a little bit about research, manuscript writing, and orthopedic surgery research at RWJ. First and foremost, I want to say a little thank you to Dr. Shisa Daka, who's my mentor last year at HSS. Many of the ideas presented in today's talk will be based off of her presentations over the last 2-3 years. So why research? I think research is a great opportunity for you guys to transform clinical guidelines early on in your career. I think personally, I find studying every single day, doing Anki, doing practice questions very, very difficult. And doing research where you're interacting with patients, and when you're able to see how a patient comes in, 6 weeks before an operation and see how they progress on the day of surgery, 6 weeks after surgery, 6 months after surgery, and a couple of years down the line, I think that at the end of the day, that's what we're all here for, and research is a great opportunity to get your feet wet. Research is also a great opportunity to develop relationships with the orthopedic surgery residents, fellows, and attendings. I've been very fortunate to meet several individuals who have kind of taken me under their wing, and from that, I've been able to attend conferences in Texas and Charleston, and most recently in San Francisco. Once you get to know these individuals, you're also more likely to have clinic experiences and operating room experiences as well. And I think research is also a great idea, a great way to expand your medical knowledge from the inside out. When you're in medical school, you blow through like months and months of material in 20 minutes, and you're supposed to understand lymphomas within 2 slides, right? Whereas if you do research, you can learn everything about, let's say, like pickleball-related injuries, and you can understand the different trends that are presenting, the injuries that they're presenting with, the hospitalization rates, and as well as the risk factors for admission. And lastly, I think these numbers, I'm sorry you can't really see that. This is from the AAMC. I think we all know that getting an orthopedic surgery residency has become increasingly more difficult in the recent years. Some of the numbers show, 5.3 research experiences for PGY1, 17 abstracts, presentations, and publications. Obviously, this is a great way to become a more competitive applicant. I wouldn't be too scared by the 17 under abstracts, presentations, and publications. What ends up happening is you write a manuscript, you present it as an abstract at several conferences, you submit it for presentation, and then ends up being published. So one project can end up counting for 3+ under that category. The research life cycle. So these are the main components of the research life cycle. It starts with literature review, study design, writing a manuscript, and eventually submitting a manuscript. And we'll be briefly going through these today. If you have any questions, please do stop me. So the literature review. I think the first and most important question is, what issue are you trying to address? Once you identify the issue that you're trying to address, you then ask, what has been published previously? Number 3, strengths and weaknesses of prior studies. I think this is perhaps the most difficult thing when you're first starting research. Once strengths can be long-term follow-up, heterogeneous patient cohort, the inclusion of multiple PROMs, validated PROMs, patient cohort that is rare, that not very many other institutions have. Weaknesses, of course, can be not generalizable. It can be limited to one institution. Be case reports, single cases, and eventually, once you compile all this data, you can say, what can I add to this existing literature? So this is just one citation that from a large literature review on transfemoral amputations, also known as AKAs, above the knee amputations. So when I'm compiling a literature review, the first thing I do is I pull up the citation and I put the PMID down. I think the worst thing that can happen is you find a data point, you write it into a manuscript, you have no idea where it came from, and then you're searching PubMed for that citation. So I always write down the PMID, and then when I'm writing it into a manuscript, I'll write the sentence, I'll insert a comment on that sentence, PMID here, and then at the very end, I can go back and say, okay, here's where this citation goes. And then whenever I move that sentence around, that source goes with it. From this particular summary, I think you want to find the main points. You want to make sure you know how many patients. So immediately we see that there are 112 patients between 1970 and 2018, so a 48-year window, who had prior TKA and then underwent an AKA. And then you want to know why did these patients have an AKA, right? So in 80% of cases, sorry. Chronic infection was the most common indication. Next, another variable that the study looked into was whether patients were fitted for a prosthesis. So in this particular case, 50% of patients were fitted for a prosthesis, and patients who underwent an AKA after 2000 were more likely to be fitted for a prosthesis. And the odds ratio was 7.3 times more likely than someone who had an AKA prior to 2000. And then the study looked at, are there any differences in SF-12 scores between these two studies? SF-12 is a quality of life measure. And what they found was that patients who were fitted for prostheses versus not fitted for prostheses had no statistically significant difference in SF-12 scores. And last but certainly not least, after AKA, 54% of the patients passed away with a mean time to death of 4 years. This range is obviously really wide, 12 days to 19 years. 2, 5, and 10-year patient survival after AKA was 81%, 41%, 47%, and 21% respectively. And then the bottom line, I think that if you can write a bottom line, summarize a whole entire study in 2 sentences, I think this shows a lot about whether you understand the study or not, right? If at the end of the study, you write a bottom line and you're not quite sure whether that was the main point, then I think I would encourage you to go back and relook at the study, find out the primary outcome, find out what exactly the authors are trying to tell you. The great thing is that the bottom line in this particular case, or in most cases, is listed in the conclusion. So study design, I think, study design, I think, is where people skimp out a lot, especially when they're trying to do a lot of research. I think when medical students enter medical school and there's this huge demand for research, by the time they're applying for residency, the goal is, let's do research now. And they skip these important steps when they're drawing up a study. I think a lot of the studies that were presented at our last research conference day were rejected from journals because they didn't necessarily think through, the study design before they went through the study. Imagine spending 3 to 6 months on a study, you submit it to a journal, even a journal where you have to pay 3 to 5 grand to publish, and then no journal's willing to take your study, right? And then even if you do get it into one of those spin-off journals, if you apply to residency with these publications that one person from across the world is going to read or nobody else is reading, I would argue that that's more of a red flag than a green flag. So study design, what goes into a study design? Again, significance of the study, you need to know the issue that you're addressing. Study aims and research questions. This might look something like, the purpose of this study was to look at, I'm going to go back to pickleball-related injuries because that's a study we did recently. So the study aims were to evaluate the rates of injury or pickleball-related injuries presenting to emergency departments between 2020 and 2022, as well as the number of hospitalizations from the injuries and risk factors for hospitalization. You then draw your hypotheses and primary and secondary outcomes. So primary and secondary outcomes, when you're looking at these outcomes, you can't just do research and not have something tangible, right? You need something that you can measure. In this particular case, this is a Kaplan-Meier curve, which I know we reviewed in the fall. Implant survivorship is a common outcome. You can look at fracture rates, hospitalization rates. You can look at patient-reported outcome measures. And then the variables. I think it's very important to list the variables that you're pulling. These may be patient demographics, sex, age, BMI, Charleston Comorbidity Index, date of surgery, date of follow-up, or date of last follow-up. And then if, let's say you request patient-reported outcomes, it's not just patient-reported outcomes, right? If you request patient-reported outcomes and the analytics person sends you back 2 patients with data that have filled out, let's say, the lower extremity activity scale, and they both have a score, and you didn't specify that, I only want patient-reported outcomes at 6 weeks after surgery, and one patient filled it out 1 day after surgery, another patient filled it out 6 years after surgery, right? Those outcomes aren't the same. So you have to, even when you're requesting PROMs, make sure you specify the time points that you want those patient-reported outcomes for. Other variables that you might look into, radiographic findings, implant loosening, things like that. Inclusion-exclusion criteria, pretty self-explanatory, and statistical analyses. You want to make sure you're powered to detect statistically significant differences in a particular variable. Again, I think it really sucked to get to the end of the study, and this has happened to me before. You do the literature review, you write up the whole study, you send everything to stats, you wait several months for it to get back to you, and then you realize that you're not even powered to detect a difference. So writing the manuscript. So this is what I thought the order of research was when I first started research. You look down, title, abstract, introduction, methods. I just started writing down. Like my first project, I went straight down, had no idea what I was doing. But in reality, research looks a little more like this. Once you have your methods drawn up in the study design, you would start with your data and results, with your figures and tables. You walk the reader through your data and results, and then you go through the methods that you already listed out in your study design. And then you discuss the major findings, and as well as any unexpected findings and the clinical significance of those findings in the discussion. You write a limitation section, a conclusion, and then you go back to the introduction. I think leaving the introduction for the fourth as those four major blocks is great, because then you can structure your introduction to lead into what your study wants to talk about. And then you can talk about the title and the abstract. Saving the abstract for last is by far the easiest thing to do, because the abstract is just a shortened version of the first four blocks there. So data and results, like I mentioned previously, you want to make sure that when you're writing the data and results, you're guiding the reader from one figure or table to another. Avoid repeating information that is already in a figure or table. I've gotten dinged for this several times on papers. A reviewer gets back to me and says, "Why did you include this sentence? This is redundant." The last thing they want to do is be fumbling between a figure and table and then realize that they're reading the same exact thing in the manuscript. Any results that you're going to be talking about, any results that you're going to be talking about in the discussion should be added if they're not in figures and text, in figure and tables in text form. Make sure your titles are informative. Make sure your headings are appropriate, and the arrangement of information needs to be in a way that improves the understanding. Right. Again, these reviewers are oftentimes surgeons. They're busy individuals. If it takes them 15 minutes to figure out what's going on in your table, your odds of getting that paper accepted for publication are significantly lower. And make sure your tables and figures can stand alone. Again, if you can't interpret what the study is looking at simply by looking at the table, I'd argue that you need a lot more information there. And avoid visual distractions. Sometimes I think less is more. There's no reason to color code something that doesn't make sense, that doesn't need color coding. So I'll go through some examples. This is actually an example from a pickleball paper that Connor helped me out with a couple of days ago. The two tables present identical information. On the left, we see that fractures, other injuries, and strains and sprains are the most common injuries, but they're not listed in they're listed in alphabetical order. So when you're looking through that table and you're looking for estimated injuries, right? Sure, alphabetical order, in a sense, like it looks pretty, but I'd argue it's much easier for the reader to interpret when you just go down the list and see, okay, fractures 29%, other injuries 25%, strains and sprains 25%. Then it goes down in terms of order of importance. These are some examples of graphs that were published in top-tier journals. Please don't do this. This is all they provided. There was no title, no commentary. I have no idea what, looking at this table, or looking at this graph, I have no idea what the different colors mean. Dose quartiles on this axis on the right over here. What does dose quartile mean? Is it what was the max dose? See, I have no idea, looking at this table, if there's a statistically significant difference between groups, right? We know that there are differences, whether they're statistically significant or clinically significant, we have no idea. Again, I'd also avoid pie charts. This is looking at the number of coronavirus cases in the UK. In the legend above, there are a lot of different parts of the UK that are listed there. I think it's very difficult to tell the differences in color. You're also looking at this particular graph. You have no idea, what does this big purple area over here represent? There are 8,000 total cases, and I have to make an estimate as to, okay, this is about maybe a quarter, right? So maybe a little less than a quarter. So therefore, it's what, like 1,700. So make sure your readers aren't guessing. As you go on and do more and more research, you kind of develop your style. This is kind of my style and the way I like to do things. You can see the outcome in the first column, and then the comparisons. We're looking at odds of implant waste by different technologies used. On the left, the outcomes are different total hip replacement implants. The comparisons in the middle are different technologies. So you have robotics, navigation, and manual. And then you have the odds ratios, confidence intervals, and p-values. So I bolded all the p-values In the title, you know that you're looking at odds of implant waste and you're adjusting for demographic and perioperative factors. And I put a comment over here. The multiple comparisons, Bonferroni correction. All models are adjusted for BMI, age, race, sex, ASA, surgeon experience, and surgical approach. And then I note that bold indicates statistical significance. So methods. Again, these should be drawn out in your study design. It should follow your results section. So going back to the pickleball study, if your first figure is talking about injury rates, you should talk about the different tests that you did to demonstrate those injury rates. You should then talk about the hospitalizations. And then the tests that are needed for the risk factors. Explain the rationale for each analysis. So to determine the injury rates, we used the weighted estimates provided by the NEISS. To examine the relationship between implant survivorship and age, we conducted a Kaplan-Meier survivorship curve, for instance. Always, always, always include an IRB statement. It should read one of the two following things. IRB approval was obtained for the study, or the study was exempt from the IRB approval because XYZ. An example of this would be, there's only de-identified data in the data set, therefore we did not need IRB approval. Use flow diagrams where appropriate. An example here, sorry, again, it's difficult to see. This was from a study that we did looking at TKAs, total knee arthroplasties for patients 35 years of age and younger. Inclusion criteria, so age less than or equal to 35 at the time of surgery. They must have had primary TKA at our institution. Exclusion criteria, anybody over 35, anyone who had prior TKA surgery. And the reason why I chose to do a flow diagram in this particular case was that we had administered several questionnaires for our patients and followed up with them at multiple time points. So we see that there are 119 patients enrolled, total of 185 total knee arthroplasties between those 119 patients. There were 13 patients with 21, representing 21 total knee arthroplasties that did not respond on the right. From there, we can see that there were 106 patients representing 164 TKAs that completed our first questionnaire. And this is where it gets a little dicey. Between the first and our second questionnaire, there were 42 patients that didn't respond. And so you guys can't see it, but it says did not respond or unreachable. And then below it, there was a subcategory within unreachable that was individuals who had passed away. This study was dated back all the way to the 1970s, 1980s. And those individuals, were 40 or 50 in 1970, 1980, and they had passed away. And then there are individuals that we were able to reach and did not want to participate after participating in the first survey. And then at the very bottom, you see completed second survey, N equals 58, 91 TKAs, a total of 65% response rate. With regards to your discussion, the first paragraph of your discussion is the most important. First of all, state whether your hypothesis was proven, list your major findings, any unexpected findings as well. And then after that, one paragraph for each important or unexpected finding. Again, for the pickleball study, injury rates increased, nearly doubled between 2020 and 2022. In comparison to previous studies that looked at injury rates between 2001 and 2009, this is an X% increase. Your second paragraph might read, hospitalizations has increased threefold since 2020. This is particularly concerning given the at-risk population, the older population that plays pickleball. And then you lead into the third paragraph of risk factors. Age over 65 at the time of injury was a risk factor for hospital admission. And this is concerning because older individuals need additional monitoring after sustaining an injury. They need to be hospitalized more frequently. And every time they go into the emergency department, their average cost is significantly greater than someone under 65. Again, follow the order in which the findings were presented in the results, compare and contrast with previous studies. And if you have any unexpected findings, how do you interpret them, right? Contrary to prior literature, our study demonstrated that maybe there was no increase in pickleball-related injuries, and that was a surprising finding. Make sure you use high-quality citations. I try to avoid URLs, websites if possible. I try to use PubMed. You'll definitely get dinged if you use anything like Wikipedia or WebMD. Do not make a list of related previous findings. Make sure that you are commenting on your results. and how they relate to previous findings. Limitations and conclusions. So the second to last paragraph should be your limitations. Don't ever write, we have no limitations in the study. All studies have limitations. And even if you do have limitations, that doesn't mean your paper is going to get rejected. You should talk about a little bit about how were they addressed. For instance, the study was only conducted at one institution, therefore the results might not be generalizable to other hospitals, other patient populations. And, you know, other limitations that you might address, you know, I think sample size is a very weak limitation, maybe short-term follow-up, but make sure that you note that there are limitations and note that you did consider them. If you don't address these limitations, there's a high likelihood that you get your paper rejected. The final paragraph is conclusion. This should be short and sweet. Most important findings, clinical significance. You can do future directions of research as well. You know, future research should examine the cost of pickleball-related studies, pickleball-related injuries, and avoid overstating results. Stay within your bounds. For instance, our pickleball-related studies, we only looked at injury rates. Even though that we saw a significant increase in injury rates, that doesn't mean we could just conclude that there's an overwhelming cost to, or there's X dollars of cost to the U.S. healthcare system. The introduction. So again, after this discussion, the first paragraph, identify the issue that you're addressing. Why is the issue important? And then you go into the second paragraph, summarize the previous studies. A lot of these previous studies are cited in the discussion, which I think is another reason why it's so important to make sure you have your citations tracked. And then you lead into, you know, this is the gap in knowledge that I've identified through my literature search, and this is why you should read my awesome study. Purposes, the last two sentences should be the purposes of the study. Again, pickleball was injury rates, hospitalization rates, risk factors, and then a hypothesis. Our team hypothesized that the injury rates would have increased significantly by 2020. Title, get the reader's attention. Make sure it's an active statement of conclusions. Here's an example. So that we did. Robotic-assisted total knee arthroplasty was associated with thinner polyethylene liners used compared to navigation guide and manual techniques. Be careful with controversial titles. A title that one of our teams submitted was learning curve for hip arthroscopy was steeper than expected. You got to keep in mind, these are surgeons, right? No surgeon likes to be told that it takes them 10,000 surgeries to be an expert at a particular type of surgery. So just keep that in mind. Again, avoid overstating your findings. And here are good examples. And then, yeah, comparable outcomes following stage and simultaneous bilateral total hip arthroplasties at 6 weeks. You kind of get a sense of what's out there, or what the study is talking about and what the study is going to be presenting on. And then your abstract. Write the abstract last. Adhere to the journal guidelines. I think this was one of the more confusing parts for me when I first started research. Every journal has different guidelines, word counts, level of evidence is the same. Disclosure statements, they vary in terms of where they ask you to put it. Sometimes it's at the end of the abstract. Sometimes it's on the title page. Sometimes you have to submit separate documents entirely. Some journals ask you to number every line. Regardless of your journal, always include purpose / introduction, methods, results, and conclusion. References. Use a reference manager. I use EndNote, and include PMID as you are writing. Quality over quantity. This is a study that one of our wonderful OSIG leaders did. Make sure you use recent and relevant studies and adhere to journal guidelines. This is another reason why you need to make sure your PMIDs are cited. Sometimes they ask you to list in terms of order of appearance versus alphabetical order in the references. Sometimes they ask you to use brackets or superscript. And once you have those loaded in, you can upload output styles. I'm happy to walk anyone through that if anyone's curious how to do that on EndNote. And title page. So this is what a title page looks like. Again, it varies a little bit from study to study, or from journal to journal. Title there, reduction in rate of implant waste associated with robotic-assisted total hip arthroplasty. Running titles sometimes requested, sometimes not. You'll have the author list, and then you'll have their affiliations as well. Corresponding author. So one suggestion regarding the corresponding author section, when you're putting your email down, put down a personal email. One of the challenges that I faced when I was leaving Yale, leaving HSS, was that I lost access to my email, and all correspondences go to that email. So if you have to go back and kind of ask for access again, and there's a deadline that you need to submit a revision by, and you miss that revision, that'd be a horrible way to lose a paper published. Emails, list your co-authors' emails, and then more recently, journals have been asking people to list the roles that everyone played within the study. Sometimes it's on the journal submission. And then for specific journal information, Google your journal name and then author guidelines, and then they'll be able to walk you through the different requirements that are needed for every journal. Submission, again, follow journal guidelines. Conflicts of interest statement, again, may be required at the bottom of the title page or on a separate form for all authors. The great thing about orthopedics is that everything is listed under the Academy website. So if you look up AAOS disclosure program, every surgeon is supposed to have their disclosures listed every 6 months. So you can kind of get an idea of what they're involved in and what kind of disclosures that you need to disclose when you're submitting a manuscript. This is particularly important, especially in like something like arthroplasty, where individuals are getting funding for research. They're getting royalties for every implant that's sold or every surgery that they perform. So an example might be XYZ has stock in J&J, receives funding for research from Stryker, and is board member of EOA and the Knee Society. Reviewers suggest and request exclusions of reviewers as appropriate. And then the cover letter. I'm happy to upload a copy of a cover letter. Essentially, you're writing to the editors of the journal and saying, this is what we did. These are our primary findings. This paper has not been considered for publication anywhere else and is not currently under consideration for publication anywhere else. All authors have completed the necessary requirements to be considered an author on this paper. Orthopedic research at RWJ. So currently I'm organizing the orthopedic surgery research spreadsheet. I know a couple of you guys have reached out to me. I'll be getting back to you guys shortly. I think research here is a little more complicated because at somewhere like HSS, individuals are incentivized to do research. So let's say they want to go up for promotion at the end of the year, then they need to submit, okay, here are the 5 first author publications that I'm getting at the end of the year. Whereas at RWJ, a lot of the surgeons are private. There's less incentive to do research. That being said, we still have plenty of research opportunities going around that we're cleaning up right now. Deanna's reaching out to a RWJ alum regarding research opportunities. One thing about alums, we ask that you please be respectful and please be realistic about what you can accomplish with these alums. Our OSIG leaders are doing a lot. They're putting a lot of effort to reach these individuals. And let's say if Calvin hops on a study and tells an attending that he can do 2 projects and he does 2 projects and does them very well, that can lead to great relationships down the line for everyone in OSIG. Whereas if Calvin goes and tells someone that he can do 10 projects and ends up doing 1, right, then you might burn that bridge for everyone down the road. We have research meetings, fracture conferences, OSIG events coming up. I think this is a great learning experience for everyone doing that's interested in research. And then we also have an RWJ Orthopedic Surgery Department Research Day coming up that we'll send details out for. So how can you help? So be creative, know your strengths. When I first started research, I hated writing. I couldn't draw to save my life. Not great with stats either. For me, I come from finance, and I was good with Excel. There are many ways that you can help out with research. Be proactive, not reactive. A paper's not going to land in your lap. I remember cold emailing so many different surgeons when I was in college before one reached out to me, and we developed a several year-long relationship that is still very strong today. Here's an example of a drawing that our medical student did for our lesser tuberosity avulsion fracture in a pediatric patient study. I think there are many ways that you can contribute to study. Here's the drawings of different hip implants used. It's not just writing, it's not just research that you're doing. Sometimes maybe you're good at videography, you want to get into the OR. Surgical technique papers are very common. Maybe you're good at drawing, you can contribute one of these drawings. Personally, for me, it was Excel. And from there, I told the surgeon, hey, I'm good at Excel. I can put together pretty tables. Would you mind if I did the introduction? And then you kind of build your way in, and then you develop that relationship. Sometimes you're really good at collecting proms, like our Dan Devine. And find your passion. So I bring this paper up. So this is Dr. Gardner. She was my mentor and my doctor when I was an athlete in college. I bring this paper up that was describing the women in orthopedic surgery, not because it was necessarily the most technically difficult paper that we had done, but because it really shows that if you have an interest in something within orthopedics, there's always a place for it in the literature. For this particular study, we sent out a survey to the Ruth Jackson Orthopedic Society, as well as an online Facebook group. Right, if you can get into medical school, you can create a survey to send on Facebook. And what we were looking at was, what are the demographics of women in orthopedic surgery? What are their biometrics, and what are their path to practice? And what we found was that most practicing female orthopedic surgeons were married, they had children. The majority of practicing female orthopedic surgeons were collegiate athletes, and most practicing female orthopedic surgeons had no female orthopedic mentors in undergraduate or medical education. Those are key findings. That's it.